Hello, myself Dr. Vidhisha Ramani, and topic of my paper presentation is neuroimaging approach to pediatric brain tumors. So let's start with that. Aims and objectives to show practical MRI patterns that help quickly identify pediatric brain tumors, to illustrate the typical MRI appearances of common pediatric brain tumor, to link MRI features with WHO tumor grade and available tissue diagnosis, to present cases of children less than 16 years of age, and to describe each case by location, appearance, diffusion, susceptibility, enhancement, and tumor grade. So let's start with the case series. Case of ganglioma in 15-year-old male patient, which is classified under WHO grade 1. Location is right occipital cortex, and MRI shows well-defined solid cystic mass, which is T2 and flare hyperintense, shows no diffusion restriction. Solid component shows homogeneous enhancement and causes minimal mass effect. So cortical solid cystic lesion without restriction favors glioneuronal tumor. These are the images shows no diffusion restriction and T2 and flare hyperintense images. Case 2 of pilocytic astrocytoma in 16-year-old male patient, which is classified under WHO grade 1. Location is brainstem. MRI shows cyst with enhancing mural nodule. Cyst is hyperintense as compared to CSF on T1 weighted images. The lesion shows no diffusion restriction and causes mass effect in form of partial effacement of fourth ventricle. So classic cyst with mural nodule in posterior fossa favors the diagnosis of pilocytic astrocytoma. And these are the images shows no diffusion restriction and cyst is hyperintense as compared to CSF on T1 weighted images. Now next is case of DNET, dysembryoplastic neuroepithelial tumor in 16-year-old male child, which is classified under WHO grade 1. Location is right temporal lobe. MRI shows multicystic bubbly lesion, which is T1 hypointense, T2 hyperintense. Susceptibility images shows foci of calcification in it. The lesion shows no mass effect and no enhancement. So bubbly cortex-based lesion with calcification and no enhancement suggestive of DNET. These are the images shows T1 hypointense, T2 hyperintense, and susceptibility images shows foci of calcification in it. And then next case is the case of low-grade thalamic glioma in 15-year-old male child, which is classified under WHO grade 1. Location is left thalamocapsular, and MRI shows oval well-defined solid lesion, which is light TNET, T1 hypointense, T2 hyperintense. Susceptibility images shows no susceptibility, no diffusion restriction, and variable or no enhancement. So deep nuclei, low-grade gliomas often lack diffusion restriction. These are the images shows no diffusion restriction, T1 hypointense and T2 hyperintense images. Next case is case of high-grade frontal glioma in 10-year-old male child, which is classified under WHO grade 3 or 4. Location is left frontal or gangliocapsular region. MRI shows predominantly solid with cystic areas with irregular margins and shows focal diffusion restriction, and susceptibility images shows intratumoral hemorrhage. This lesion shows heterogeneous enhancement and causes mass effect compressing the frontal horns. So diffusion restriction plus hemorrhage plus hetero enhancement is highly suggestive of high-grade behavior, and these are the images shows focal diffusion restriction and susceptibility weighted images shows intratumoral hemorrhage. The next case is case of diffuse midline glioma in 7-year-old female child, which is classified under WHO grade 4. Location is brainstem, and MRI shows irregular, predominantly solid mass with internal cystic areas in it, and often shows no diffusion restriction, and susceptibility weighted images shows hemorrhagic foci in it. And this lesion shows focal or central enhancement, and due to compressment of fourth ventricle, there is a hydrocephalus. So brainstem expansion, T2 heterogeneity, plus or minus hemorrhage, suggestive of diffuse midline glioma. And these are the images shows no diffusion restriction, and susceptibility weighted images shows foci of hemorrhage in it. Okay. Then next case is case of cerebellar hematoma, which is non-neoplastic condition in 4-year-old male child. Location is left superior cerebellar hemisphere. MRI shows well-defined solid lesion, which is isointense to gray matter on both T1 and T2 weighted images. It shows no diffusion restriction and no enhancement. So non-enhancing gray matter isointense lesion without mass effect can be hematoma. And these are the images shows the same. no diffusion restriction, and this lesion is iso-intense to gray matter on both T1 and T2 weighted images. It is cerebellar hematoma. The next case is case of supratentorial ependymoma in 5-year-old child, which is classified under WHO grade 2 or 3. Location is left frontoparietal lobe. And what does the MRI shows? Large heterogeneous solid cystic mass, which is T2 hyperintense. Susceptibility images shows calcification and hemorrhage, and mild edema and heterogeneous enhancement. So supratentorial lesion with calcification and solid cystic lesion suggestive of ependymoma. MRI shows solid component shows diffusion restriction, T2 hyperintense lesion, and susceptibility images shows hemorrhage and foci of calcification in it. And this is the last case of papillary meningioma in 6-year-old child, which is classified under WHO grade 2. Location is left parietal convexity. It is extraaxial lesion. So MRI shows dural-based extraaxial lesion, which shows heterogeneous enhancement and mild perilesional edema. So extraaxial lesion with broad dural base in child is suggestive of meningioma. Yes, MRI do shows often shows for diffusion restriction, and this is the dural based extraaxial lesion, and susceptibility weighted images shows multiple foci of hemorrhage in it. Okay. Imaging pulse and pitfalls. Pulse we already discussed, and pitfalls. High-grade gliomas may mimic abscess or effective demyelination because both can show diffusion restriction. Posterior fossa tumors can overlap in imaging like medulloblastoma, ependymoma, and pilocytic astrocytoma. Hematomas and other non-neoplastic conditions may simulate true tumors on initial assessment, and enhancement patterns are variable. So don't rely solely on contrast uptake for grading. Discussion. Pediatric CNS tumors demonstrate the wide histological and imaging variability. MRI provides critical information on location, morphology, internal architecture, calcification, hemorrhage, and diffusion behavior. Certain patterns are highly suggestive, like cyst with mural nodule, pilocytic astrocytoma, bubbly cortical lesion is disseminoplastic neuroepithelial tumor. However, there is significant overlap. High-grade gliomas versus abscess and demyelination, and posterior fossa tumors often indistinguishable without histopathology. Acknowledgements is Department of Radiodiagnosis, JMC Surat, and these are the references as mentioned. Okay, thank you.